I thought it would be something a little different to talk about a topic that you probably already know a lot about, but just to refresh your memory on some of these issues. Let me see if I can, there we go. So just to mention about, this talk is mainly going to be about Varicella Zoster, obviously, or shingles. This was an entity that was recognized just back in 1965, and it was an English general practitioner. His name was Edgar Hope-Simpson, and he happened just by observation and seeing in his private practice lots of children with varicella or chickenpox and the lesions of shingles, and he thought they looked a lot alike. And by doing a lot of inductive reasoning and just seeing patients and doing what we normally do in ID, he put it together that because these looked the same, that it probably was another manifestation of varicella zoster virus. So he was the one who led the way on us actually recognizing the link between varicella and zoster. We know that this is not an uncommon disease. The estimate is that there are 1 million cases per year. Usually these occur in people over the age of 50 or higher. And as you see the chart in the middle, that you see the starting predominantly around age of 50, and then the rate per 100,000 goes up after that. It is interesting, CDC guesstimates that about 1 in 3 persons will develop zoster over their lifetime. And there is another source that I didn't cite on here, but says without Zoster vaccine, which we'll talk about a little bit more as the slides go along, the persons living to age 85 will have about a 50% chance of getting shingles. So the older we get, the worse things go for us. So we can expect to see more cases, and there was a publication from CDC that noted, and they don't really have a good idea why, but the amount of zoster that we're seeing has actually been increasing. It doesn't seem to be tied to any particular factor that people have recognized so far. But obviously we're getting an older population, and that's a big risk factor for zoster, as we just mentioned. And you see on here where we're right in the middle of the graphic below that, and looking at populations of 50 and older. 2020, where we're sitting, we expect to see over the ensuing 10 years or so a pretty significant decrease from 2010 to 2030, about 33%. So we can expect to see more of these cases as we go along. A lot of these we won't necessarily see because they'll be seen in the outpatient setting, and we're hoping that our practitioners can recognize zoster and can manage them fairly expeditiously. So it all starts, this unfortunate kid. It probably could have been me, because the few things in my life I remember when I was really young was getting chicken pox. Although I thought they said I had chicken foxes, and I hadn't been around any chicken foxes that I knew of. So once you get chicken pox, and hopefully don't have complications from that, then most of you realize then that you go into the virus actually getting into nerves, and by retroaxonal flow going down to dorsal root ganglia, as you see depicted with the little green dots going in dorsal root ganglia, where it just lies dormant for most of your life, and it may never reactivate in some people. But if you're unfortunate enough to where it does reactivate, then it goes by axonal flow back up to skin, and usually, and still not clear why, just in one or closely associated dermatomes, you have reaction. But then it goes to the skin and has manifestations, and unfortunately this is a little too small probably to be seen clearly, but this is just depicting where it would come out on a dermatome in this person's abdomen. That's the little small pig, but you'll see plenty of pictures as we go along. One of the earliest, I thought, nice papers came out of CID in 2007. It was a nice review on the management of acute herpes zoster, and talked about pathogenesis, epidemiologic aspects, clinical aspects, and complications, and reviewed the literature on treatment of zoster. And it was just a really nice resource. More recently, this paper came out in New England Journal in 2013. It also is a really nice discussion. It starts out with this vignette, which is not that uncommon from some of the patients that we see. Jeff Cohen works at NIH and is part of their virology service, so a really good author for this. But I think this is what we see: is a 65-year-old man comes in with a rash of 2 days duration on his right forehead, hopefully not there, but would come in with what sounds like could be a lot of different things, but in this case, ends up being shingles on his right forehead with vesicles and pustules. A few lesions on the right side and the tip of his nose, which is a bad prognostic sign, and blurring of his vision. And he has some altered sensations in that area, and how does he need to be evaluated and treated? So that's what I'd like to kind of go through and just refresh your memory on today. We know that there is a potential prodrome in people. 70–80% of people will start to have some kind of discomfort or sometimes just frank pain in the dermatome where they're going to have lesions break out. And of course, it's just classic, right? What else could it be? The pain is either constant or intermittent, frequent or sporadic, may or may not interfere with sleep. So it could be lots of different things. And that's problematic for us because it doesn't help getting that kind of a history from someone. We had, when we were part of the shingles prevention study, to ask a long list of, for them trying to quantify and qualify the symptoms that they were having. And there are a lot of different ones, but a lot of the terms that people used that were more commonly relayed to us was burning, shooting, stabbing, throbbing, aching sometimes. I mean, all kinds of different ways people would describe the pain or discomfort they had. I know you probably have seen this in some of the patients, but when they get allodynia, you just lightly touch the area and it is absolutely horrid for them. Even wind blowing across skin sometimes is almost intolerable. The prodrome is usually 2 to 3 days in duration, but can last longer in some people, but usually is not that long. But the problem is, because this is so nondescript, people start looking for a lot of different causes for this and may actually forget to consider that this could be a prodrome of herpes zoster. The rash is interesting because it is, as it starts out, mainly macular, and sometimes that gets missed, but again, it's nonspecific, and you really do have to wait, usually 1 or 2 days, and see if you start seeing papules that progress to vesicles. The vesicles are usually start appearing on days 3 and 4 in most people, and are usually consistent in description with them being grouped and clustered, and usually on an erythematous space. So that's what you want to look for: clustered, grouped vesicles, usually associated with an erythematous space, and sometimes these can be confluent. If you start having vesicles that keep appearing after a week's duration, I'd be a little suspicious that maybe they had some kind of immunodeficiency, and we certainly cause immunodeficiency in many of our patients trying to treat underlying diseases. The other term I'd just like for you to remember is pustulization or pustulation, because you'll see the vesicles being pretty clear, but just after a few days or so, they start getting this kind of opalescent or whitish appearance, and it might be confusing that they're infected. They're not. Those are literally white cells that are floating inside of that vesicle fluid, and I would recommend, if possible, to leave those vesicles alone. And unfortunately, we have patients that, well, they had those blisters popped up, so they popped them, and now they can get super infected. But it's that appearance does not tell you that it's infected. It tells you that they're progressing along with their disease. The lesions usually then do undergo, some of them do open and ulcerate, but in general, you start seeing them, even if they don't open, start crusting over around 3 to 5 days after the initial appearance, and the crusts are usually, after they crust over, gone maximally within 3 to 4 weeks. In some people, they can scar. They can cause hypo or sometimes hyperpigmentation. So when you're letting people know what the outcome might be, those are some of the things to discuss with them. less frequently, literature suggests less than 20% of patients will have significant systemic symptoms, but they do appear in some people with fever, headaches, malaise, or fatigue. And when you're looking at mucous membranes, when you're looking at facial nerve presentations of this, you can see with a V3 zoster involving the oral mucous membranes that what you're going to see are shallow erythematous ulcers. You really probably are not going to see vesicles in the mouth. I won't say never, but in my experience, I've not seen any at this point. Then we talk about dermatomes, and here's a classic Frank Netter drawing that we used to use in explaining to patients where that their outbreaks are, and more often than not, they do follow these dermatomes. Occasionally, they can be more than one dermatome. But these are the ways that we would certainly want to describe this as being a dermatomal distribution. There are some other diseases that look like that they may travel in dermatomes, some other dermatologic conditions, and I won't really talk about it today, but there is a confusing entity that's known as dermatomal herpes simplex. I mention it to you because some people say, I keep getting zoster over and over again in the same place. There's a pretty good chance it's not shingles that they keep having recurrent. It's really dermatomal herpes simplex, and the way to differentiate is by doing PCR. Get a VZ PCR and at the same time an HSV PCR. We've used that, and on some things we could have sworn were going to be zoster. You find out it was herpes simplex. Even in the shingles prevention study, I believe we had 43 across the study of things that looked like they were going to be zoster, but in fact ended up being herpes simplex. As I mentioned, when you're looking at trigeminal nerves and the facial manifestations that you can see with this, we talk about the first, second, and third branch of the fifth cranial nerve, and obviously we abbreviate it because we always have with Roman numerals, and this is V1, V2, and V3 distributions. So you can either see this involving the forehead down to the bridge of the nose, tip of the nose. V2 is kind of overlaps a little bit with that. Those, as you know, are usually associated if there's problems with eye manifestations. And V3 can involve hearing loss in some people. And also on oral exam, it's really interesting. I couldn't find the picture, but when I was a fellow at Tampa General, we got consulted on a patient, an elderly patient, 80 some years old, who had had frequent falls and was getting evaluated for that. And on an oral exam, they had ulcers on their tongue, but only on half of their tongue. She was heavily wrinkled on her skin, on her mandibular area, but if you look closely, she had some fine vesicles that were starting to erupt. So in fact, she didn't have a cardiac or a CNS issue for her frequent falls. She had vestibular issues because of V3 zoster that responded very nicely to antiviral treatment. So this is a classic. I mean, I don't think anybody would miss this on presentation as being herpes zoster or shingles. It just has that appearance of going around the Latin singulare for that was modified to being shingles. Is like a belt, but again, as you notice, if we'll go back a slide, it stops at about the midline in most people. Occasionally you'll get a little crossover, but the vast majority of people, this is going to be just on one side in that dermatomal area. Classic shingles, you see group vesicles, some of them have coalesced, and they're on an erythematous base. Just looking at ophthalmic zoster, tons of pictures. The one that classically is used is actually a patient of Mike Oxman's, who was the study chair for the shingles prevention study. And as you see, this is already crusted, but has bad prognostic signs because she has the side tip of her nose involved. She has Hutchinson sign. And the concern is obviously with eye involvement. If you think that there's eye involvement, then you really should have them see an ophthalmologist because they're going to be probably recommending topical treatment and other things to try and save vision in the eye, which can be affected. The ones on the right-hand side is one of our study patients. You can always identify those by that wonderful little ruler that we stuck onto people so we could get measurements. We had other ones as well, but most of the patients don't have ophthalmic zoster, interestingly enough. Most of it is going to be on the trunk or the limbs. This is an unfortunate patient I saw when I was an ID fellow. He unfortunately had small cell cancer of the lung, and it developed V2 zoster, and did have some crusting on his hard palate. But this was zoster and responded well to treatment. It did get super infected. Since he was on chemo, he ended up getting Staph aureus and survived that, but unfortunately didn't survive his lung cancer. I just wanted to show you a couple of pictures so to try and help you understand the difference between multi-dermatomal zoster and disseminated zoster. This is multi-dermatomal. This is one of our obviously study patients with the ruler stuck to them. And what you see is on his back, looks like that he has more than one dermatome that's involved, especially higher up around the shoulder area going across the scapular area. And you look and it comes around onto the front. So this is going to be one of those ones that I think confuses people because they think this is disseminated. This really is not disseminated zoster. This is disseminated zoster. Usually we see this in people that are immune compromised. Occasionally you'll see it in somebody who has an undiagnosed immunocompromising illness, but most of these people are going to have something wrong with their immune system. The reason I mention this to you is because for infection control purposes, this is different. Most people with herpes zoster, we would just put on contact and standard precautions. Most of these are treated as an outpatient, as you've seen with some of those where people aren't using any infection control practices in their offices more often than not. But this one's a little different. That one is just contact, standard precautions. This one is airborne precautions. So these people can have this not only under skin, but getting into viscera, getting into lungs, and occasionally, really uncommon, but getting into their GI tract. So this is more concerning. This is really not that common. It's hard to even find pictures of people with disseminated zoster. And I'll be honest with you, if you look at CDC's webpage and its description of disseminated zoster is not correct. They're describing multi-dermatomal. And yes, I pointed that out, but I haven't heard anything back. And just to show you how unstereotypical this can be, this is one of our study patients who called us. They were told to call with any issues that they thought might be shingles, which we discussed with them. So she came in, she had these few little starting to crust over vesicles that you see on the back of her arm. She had an area where she thought it was just her watch irritating her wrist area there, as you see. And interestingly enough, when you looked at her hand, that's what was really interesting. She has some vesicles on her hand in between her third individual web space. In our study, everybody had VZ and HSV PCR done. This was VZ positive, HSV negative. So I already mentioned a few of the complications. We do worry neurologically about people getting herpes zoster and shingles. The big deal, we'll mention just a little bit more in a second about postherpetic neuralgia or PHN. But obviously the other things, as I mentioned, they can get a Ramsay-Hunt syndrome from this and lose hearing or decrease hearing. They can also get a Bell palsy from this, one of the differentials for Bell palsy. Occasionally, people can get encephalitis from this. We already mentioned hearing loss. And the other issue is with more data coming out for the first 30 to maybe 60 days, an increased incidence of stroke or an MI. And we'll touch on that again in just a moment. The eye loss can be either because of loss of cranial nerve, or I'm sorry, of eye movement because of extraocular muscle involvement and loss of movement from that, or you can actually get an optic neuritis from this, but most of the time it's going to be a keratitis, and that's what's concerning for the ophthalmologist because loss of vision from that and scarring. Cutaneous, we mentioned in bacterial superinfection is something to be concerned about and to have the patients watch for. Visceral, as we mentioned, usually more associated with disseminated, although it doesn't have to be. There are reports about people having pneumonia, myocarditis, pericarditis, and other things you see listed, and really no cutaneous manifestations. Those are really hard diagnoses to make, and really makes one pause if you're just not sure to think about, could this be one of those really unusual cases of herpes zoster? Antiviral therapy, most of you are familiar with for non-immunocompromised patients. Acyclovir, famciclovir, and valacyclovir are listed. There is data now that really, I would call it punitive dosing for acyclovir. It's 800 milligrams, 5 times a day for 7 to 10 days. Finding people to take something 5 times a day, they're a hero, I think, if they can remember to take it. If it's something that's burning and hurting, yeah, but as it starts to heal, the incentives to keep taking it sometimes goes down. The better drugs are the prodrugs, either famciclovir, which gets cleaved to its active drug penciclovir, or valacyclovir, which is a valine ester of acyclovir. Both are better absorbed, give you higher levels, and are probably the better agents now that they've become generic. For immune-compromised persons, especially if they have neurologic issues or if it's going to be disseminated, you probably are going to want to start, and then you could de-escalate to oral, but to start with IV acyclovir doses that we usually use, 10 milligram per kilo, for 7 to 10 days, depending on what's going on. We usually treat for 7 days. And most people with eye, you can certainly consider extending that to 10 days. Or if somebody just doesn't seem to be healing as quickly, you could extend our treatment to 10 days. An alternative could be foscarnet, and then you have to deal with all the side effects, some of which are listed over on the right-hand column. I've not had to use foscarnet. I know that people who have had recurrent issues more with herpes simplex, that's certainly a very viable option and not uncommonly used, but it is a potential consideration even for zoster. So there are a lot of things to think about with this. Is not only managing just the outbreak of zoster, but then trying to cool it down. Some individuals are proponents of using short doses of corticosteroids, and I think that's fine. In our study, we did not because it was a vaccine-related study. Controlling pain, if it's there, I would strongly suggest that if people can come in to be seen and started on treatment within 72 hours after the outbreak of the rash, and you can shut down viral replication, the chances of PHN seem to be significantly reduced. So the earlier that you treat, the better. And if you think about this, the big issue with PHN is that you've got a lot of viral reactivation in dorsal root ganglia, which causes a lot of inflammation. If you can shut down that inflammation and shut down viral replication, you can decrease the damage that's done to that dorsal root ganglia and stop some of the, but not always, some of the manifestations of PHN and the long-term problems associated with it. And those require sometimes topical agents like lidocaine, anticonvulsants, gabapentin, pregabalin. We try and stay away from narcotics and use some non-narcotic analgesics if possible with patients. So just to kind of recap with this, that most people who are going to probably benefit the most from antiviral therapy for this are immunocompromised persons greater than 50 years of age and with severe pain or severe rash. That's not to say I wouldn't treat everybody, but data to look at outcomes, they seem to do better if you treat them early on or at all, if they fit into any one of those 3 groups that's on there: immune compromised, older individuals, and the ones who manifest pain, significant pain early on with their disease. They certainly can, if you're using antiviral agents, help hasten the resolution of this disease, but there's not any convincing data that shows that it reduces the risk of postherpetic neuralgia per se. I already mentioned to you, I think the preference is to use prodrugs more than acyclovir because of higher dosing and ease of administration. 3 times a day is certainly easier than 5 times a day. And anybody that has what looks like it could be facial zoster, especially in V1, V2 areas, need to really see an ophthalmologist just to make sure they don't need some eye-specific therapy for this, which may mean in some cases there is data of using prophylactic acyclovir trying to prevent a recurrence in the eye area. Not a huge amount of data, but there is some, and it's very interesting. We already mentioned PHN, and not to talk about the management of PHN, but how do we prevent that? Because I'm not reading the slide to you, but we've already discussed a lot of this. The biggest issue is allodynia with people that, even movement under clothes or just air moving across there can cause excruciating pain and really alter their activities of daily living to a significant amount. So can we prevent that? We know where that most of this occurs. It's starting around 50 years of age, but really takes off at age 60 and above. And that was actually Dr. Hope-Simpson's original data that I showed you. And, I did mention to you that both chickenpox and zoster are associated with strokes and MIs. With strokes within 6 months of a rash, that increases it from 1.6 to 4-fold higher. And for zoster, obviously, the biggest risk is going to be with herpes zoster ophthalmicus or HZO. We do know that CVA events can be reduced with antiviral therapy, and there's more data coming out associating increased myocardial infarction rates with shingles for the first 2 to 3 months after the manifestation, and then falls off after that. So if we can prevent people from having an outbreak of zoster, maybe we could prevent some of these other comorbidities associated with that. So the first vaccine that we had experience with at the VA as part of the VA cooperative 403 trial was the shingles prevention study, which was looking at giving live attenuated, the same OCA strain as you used to try and prevent chickenpox, but a much higher dose. It was 14 times the strength of varicella vaccine. It was, when it was licensed, it was indicated for immune competent individuals over 60. The FDA had licensed it for 50 through 59, but there's a problem with that because the durability of the vaccine, which our site also participated in, as I'll mention on a follow-up slide here, is pretty short-lived. It starts falling off after 5 years, and is the efficacy of maintaining an antibody pretty much falls off at around 7 to 8 years. What are the positive was it's a one-time subcutaneous vaccination, not an IM, and it was one time. And the downside was that this had to stay frozen. It had to be monitored to make sure it stayed within certain temperatures, because once that you reconstituted this and it wasn't frozen anymore, you had to use it absolutely within 30 minutes. The better the time of administration, you could use it within 2 to 5 minutes after that you reconstituted it. That's the best, because even in the vial, then you would see the efficacy of the vaccine really falling off. And so if you gave it after 30 minutes, it probably isn't going to be too helpful. This was the paper that came out from this huge study, and you see lots of co-authors because that was who was doing the work. And the data from this was really interesting because, looking at how much shingles could you prevent, from all the 3 tiers that were evaluated, there was an overall 51% reduction in shingles versus placebo. The highest was in people, as you can see down at the bottom, in years between the age groups of 60 through 69. Not quite as robust in 70 through 79, and not quite 20% in people over the age of 80. And I've had some people say, well, why even give it to them? Well, it's kind of a 1 out of 5 chance that they could get efficacy in not getting shingles from just that. And I think if it were me, and that's all that was available, I might not be averse, because remember, we talked about people over the age of 80 probably having about a 50% chance of getting it. Anything you can do to reduce that might be helpful. Decreasing the incidence of postherpetic neuralgia was almost 40% reduction overall. It's interesting when you look at the 60 through 69 groups that there was a 5%. But remember, these people were really not getting a whole lot of shingles anyway. So the chance of PHN you would expect to be lower in this group. In the 70 through 79, it was a little over 50% reduction, and even in the 80-year-old group, it was a little over 25% reduction. So not bad data. Could have been better, but that's what it is with this live vaccine that we were giving. I had a lot of other questions. So with this, how soon can you give this vaccine, the live attenuated vaccine, the Zoster Vaccine Live or ZVL? When can you give it after shingles? Realistically, when you get an episode of shingles, you're getting better than vaccine. Live attenuated has a reasonable amount of live viral particles, but when you're comparing it to an episode of shingles, where that you're getting millions of plaque-forming units versus a vaccine that's got maybe a couple thousand of viral particles in it, you get much better stimulation, both T cell and B cell, than you would with a vaccine. So there's no rush if people are not immune compromised to have to give vaccine. And in the study, when they compared it, that the immunity after Zoster was similar to that within the first 3 years after getting vaccine. So we usually told people you could wait 6 months, you could probably even wait a year before you needed shingles vaccine. But most people remember that episode of shingles. They don't want it again, which is pretty uncommon, but can occur. They have shingles more than once. So they really would like to have it the day after they had shingles episodes. We already mentioned about durability of Zoster and being part of the long-term persistent sub-study, which attempted to look at this. The immunity was pretty much gone within 5 to 8 years. And that's why the ACIP did not recommend giving this vaccine to people in the 50 through 59 age group, especially in their early 50s, because if this falls off, by the time that you're 60, when postherpetic neuralgia starts going up significantly, the vaccine efficacy is probably going to be gone about the time that you really would need it to try and prevent an occurrence of shingles and an increase in PHN. So it was a great first attempt. It certainly bought us several years of being able to vaccinate people, but we have a newer vaccine now that's a recombinant subunit vaccine that's looking at using an external glycoprotein E with VZV and a newer adjuvant, and the results were really interesting. The downside is that you need to get 2 intramuscular vaccines within 2 to 6 months after the initial vaccine is given. Another positive, though, with this is that it just needs to be refrigerated, not frozen. And after it's reconstituted, it's stable for 6 hours. So this would be great if you knew that a patient was coming in that day and they didn't show up on their original time, but maybe came in a couple hours later. The vaccine would still be useful. The other downside with this is, as far as adverse events, since you have an adjuvant with this vaccine, there are more injection site reactions and other potentials, fever, myalgias, etc., associated with this more than with the live attenuated vaccine. So it is recommended for immune competent adults age 50 or over. It's also recommended for immune competent adults who got prior ZVL. And it's preferred by a slim margin in the FDA and actually more of the ACIP review by a 1 vote that they were looking at it to see and watching the data to see about using recombinant Zoster vaccine over live attenuated. No great data to really say that, but when you look at the amount of activity that this vaccine has over the other, it is pretty interesting. So this is what Dr. Dooling at CDC presented at the Advisory Committee on Immunization Practices, or ACIP meeting. The yellow bar that you see there, and it says HZSU, but that's the recombinant vaccine. The other are 2 different studies using live attenuated And what you see across the board is vaccine efficacy, and 97%, 50 through 59, 60 through 69, a little reduction when people got older, but not like you would see with live attenuators, 91%, and you see the others that are a little less than 50%, and some significantly a little bit lower than that. So as far as efficacy, there seems to be significantly better efficacy with this vaccine. It hasn't been around long enough to know what durability is at this point. And so we know that for at least 5 years that it seems to be efficacious, but we really don't have an idea how long that this will last. Will it last 10 years or longer? I think we'll have to wait and see the more the people have been vaccinated and their follow-up. There doesn't seem to be any data or any concerns that it would be less safe or less effective when administered at intervals of less than 5 years, if we would need to do that. And as we mentioned, in people who are over the age of 70, that there was a little lower efficacy, but I think that we're going to just need longer-term follow-up outside of a clinical trial to see how that efficacy is in the real world and how long that it lasts. Obviously, people were very interested in this vaccine, which, because that it was the primary vaccine chosen by ACIP, ran into a lot of shortages. When people wanted it, they wanted it now because they didn't want to get shingles. And if they, in the interim, gotten ZVL, then can I get this right after having ZVL for a few months? It's not really clear. The expert opinion from the ACIP panel was that you should not give it less than 2 months. It's probably best that you don't give it right after an episode of shingles because they really don't need it, but patients are going to want vaccine. It doesn't seem to be harmful at that point. But again, it's something that really doesn't need to have a rush put into it unless they were going to be put on a medication that would be immune compromising to them as chemo or some of the other agents we use to treat other diseases that might increase their chance of getting shingles. And I did mention the increase of local site reactions. The data with immunocompromised is just not out there for approval. There is some emerging data that it seems to be okay with HIV patients and perhaps with dialysis patients, but it's not a recommendation at this point by ACIP to give it to immune suppressed. So what is okay for immune suppressed is low dose, less than 20 milligrams a day of prednisone, or if they're just using inhaled or topical steroids, or that they're anticipating immunosuppression, which we just kind of talked about, or that they've recovered from an immunocompromising, illness. Part of the problem is that these studies excluded people who were on higher doses of immunosuppression. Obviously, you don't want to confound your data having immune-compromised patients in with your immune-competent persons, but those trials are ongoing, and hopefully we'll have some other recommendations soon. So just to kind of finish some things out, I just wanted to show you some pictures and to see what you think. I know you can't really say yes or no, but this is a picture, and as you can see, it's from one of our study patients. We do know absolutely that there's some people who did not have Varicella Zoster. They did not have shingles.
No shingles.
No shingles. Somebody said no shingles. Okay. I will tell you this one is actually shingles. And you're seeing the ulcerations that right after the vesicles that had been eroded, probably because of a shirt that they were wearing. But this was actually PCR positive for VZ. What about this one? You can see that there are vesicles on the side of the neck going up behind the ear, kind of in a C2 distribution. Do you think that's shingles? My answer would be it'd be better if I could see them in person, but pictures sometimes don't look like it. But this one actually is. Yes. This one is shingles. As you see, these kind of group vesicles, it's a little washed out, so you can't really appreciate the erythematous base, but absolutely it is. What about this? Well,
No.
you see. You see some erosions, and yeah, and it's certainly an older person, but it's pretty extensive. Now, this one's a little tricky. It is shingles, but it's in a patient with psoriasis. So that's why you see this really kind of unusual, almost bizarre manifestation. So again, it's something when there's an underlying potentially immune suppressant illness, and I'm not sure what treatment they were getting. This is not my patient, but it is a little tricky with people like that. The last one that I will show you is this one. Is that shingles? As part of our study is before we had to stick on things, so we're just using the ruler from a swab. I will tell you, it could be.
Yes.
But it's not. This is herpes simplex. We saw a few of these that manifest. There was one patient who we had been following in study, been vaccinated, but we didn't know if they got placebo or a real vaccine, who ended up at Tampa General with some cardiac issues. So we went to Tampa General to see his ulcerations on his gluteal area, who one of my ID colleagues down there had already seen him, appropriately started him on treatment. And it ended up that we got there in time enough to get really good PCR and herpes simplex testing. And this is not the same person, but it was the same with this one. These are PCR positive for HSV. Now, remember that, when you're talking about genital herpes, we think about them having outbreaks on the anterior side around genitalia, both in men and women. But if this gets into sacral ganglia, the outbreaks can be in the gluteal area. Saw that at Moffitt in the past with the guy who was not happy when we got the test back that it was herpes instead of zoster, because now that's another potential social issue. He was married, and how do I explain that to my wife? Because I have been married for many, many years and not ever have had any other relationships while I've been married. It was probably a prior infection that lied dormant until he got immune suppressed. So it could be, but in this case, it's not. So I'd like to thank you for your time, and I hope this was helpful as just a review. If you have any questions, I'd be happy to try and answer them for you at this time.
Any questions from the group? I had a question or clarification, Dr. Toney. It seems like we get a lot of consults. We've gotten a lot of consults, e-consults, I should say, about the recombinant zoster vaccine and its use in immunocompromised patients. And I know you addressed this. And I guess the issue is that, and it stems from some misunderstanding between the difference between recombinant zoster vaccine and the live zoster vaccine with regard to immunocompromised patients. With the recombinant zoster vaccine in immunocompromised patients, the issue is not necessarily safety, right? But it's more efficacy, that it may be less efficacious, because I think a lot of people still think about the live zoster vaccine presenting some issue in terms of safety with immunocompromised persons. That's not really the issue with the recombinant zoster vaccine, right?
Correct. Because if you think about it, you're looking at just taking a piece of the outer membrane. So it's not a live virus. You are giving it with an adjuvant, which is one of the reasons why I think you're seeing a higher vaccine efficacy. And as I mentioned, in a lot of people, of individuals who've had this will tell you that it isn't the easiest vaccine to take. Then people can get a sore arm, they can have a low-grade fever, not feel well for a couple of days. But I mean, if you look at the data and the efficacy, that may be a trade-off, unfortunately, for getting better coverage. If you're looking at live virus, I mean, it is attenuated, but that's something you don't necessarily want to give to people who are immune compromised, because it can replicate. That's one of the contraindications to giving that vaccine, is if they're on suppressive therapy for herpes simplex. They'd have to stop that for at least 24 hours before getting the vaccine, or it kills stop the virus from replicating. Doesn't kill them, just keeps them from replicating. So I agree with you. I think that people do not understand that there's that much of a difference. I think our newer vaccine, it's a little more complicated because you have to have 2 doses of it to get maximal treatment, but even getting one is not bad from some of the data that was coming out. It certainly is easier for practitioners to keep if it were in, outside in primary care, because this is something you could keep in a refrigerator, not have to monitor a freezer like you would with live attenuated. But yeah, I think there's still confusion. There's confusion with infection control between different manifestations of this. And there was one patient I saw him call for a week, and it was a guy who had V1 Zoster, already been seen by ophthalmology. Everything was crusting. And that part of it looked like it was way on the way to healing. But he was there with his son, and the guy was watching a TV that was turned off, and he kept having his hand like he was holding a cigarette, moving it back and forth. And I asked his son what he's doing. He said, well, he says he's watching football on TV and smoking a cigarette. So that was the first case I saw that I think he probably had zoster encephalitis. So, it is something that we will see some of the manifestations of. But infection control, really the only thing you need airborne for is disseminated. If they're not immune compromised, that's another one where you might consider, depending on what's going on with them, airborne. But for most, all you need is standard and contact. And I think that's another big takeaway with this.
As a follow-up, I was going to ask, with regard to the recombinant zoster vaccine, do you see any anticipated changes in the age guidelines for recombinant zoster vaccine?
Yeah, I don't think so, because the reason to give this, initially was PHN. The only thing that might change that is if you started seeing more younger people having like strokes or MIs, trying to prevent that. I don't know that that data is there yet to really say, well, we're going to, vaccinate 500 people to prevent one person from getting this. I think that's going to be one of these cost-benefit issues people are going to argue over. So I think starting at 50, though, is actually better, and maintaining that vaccine efficacy. It'll be interesting to see how long it lasts. From some of the earlier data, like I talked about, it looks pretty good, but I'd love to see, 10-year data. And if it still looks, the vaccine efficacy stays pretty much where it is, I think that would be probably a winning vaccine. But it may be that we have to revaccinate people. We just have to see what the data shows as we go along.
Other questions from the group?
Well, thank you all for your attention and being able to get into us really social distancing by electronic means, a new paradigm for medical education.